I'm going to first let you know, obviously this is critical for the hospital, it's critical to our risk management programs, it's critical to our staff, and most importantly, it's critical to our patients to know how to be transparent, how to disclose when necessary, how to apologize, and even how to make financial offers when appropriate. So I want to talk about, just for a moment, a new law in Massachusetts, very important for the conduct of this combined grand rounds today. As everyone knows, the new Massachusetts healthcare law signed into action at the end of 2012. And there are many areas of this very complex law. But one of the key areas of the law that's relevant for today is what the language says around unanticipated outcomes and mistakes. And be aware that what I'm going to tell you in the next couple of minutes emerged in the legislation as results of consensus that did involve the Massachusetts Medical Side, Massachusetts Bar Association, Massachusetts Academy of Trial Attorneys. And the core of this new law that we're going to be most interested in is, number one, there are stronger apology protections, including statements of explanation, responsibilities, or regret that we make to the patients. And secondly, that there's a mandatory 182-day pre-litigation notification period, including during that period that if someone is essentially filing a claim, they cannot go ahead and file a lawsuit, but they need to explain to you in exquisite detail, which will involve lawyers, why they are essentially making a claim against you, and make available all medical records for you to either decide that you want to try to settle the claim or you want to try to defend yourself should it move to litigation. But the most important thing to take home today is that disclosure is now the law of the land in Massachusetts. It's required. So this grand rounds is particularly timely because you have to do this. Quote from the law, in situations where a patient suffers an unanticipated outcome with significant medical complication resulting from the provider's mistake, the healthcare provider, facility, or an employer agent of a healthcare provider or facility shall, that means must, fully inform the patient when appropriate the patient's family about said unanticipated outcome, and then a definition of unanticipated outcome is provided here. The law, in addition to obviously the need to disclose, does provide protection that one's statements of apology or regret or admissions of mistake or error will not be admissible in court against the physician or in administrative proceedings. Right now, if a physician apologizes for an error, that hearsay evidence, unlike other areas of the law in a malpractice case, is allowed into court. And that's why this protection is important. But there's an exception to that protection. And that exception is very important. We don't know yet how this will play out. But if the person who makes these statements to disclose what occurred, or someone who's a defense expert in behalf of the defendants, when questioned under oath, makes some type of inconsistent or contradictory statement as to material facts or opinions, then the disclosure would be admissible in court. So it's a very important exception to be aware of. The take-home message there is do not speculate. Do not hypothesize what might have happened in an adverse event. The facts and only the facts, ma'am.
Hey, Stephen.
Hi there.
Hey, Dr. Mark Hershey. I'm an anesthesiologist. How are you?
I'm doing well. How are you?
Sorry it's been so late. I know it's been a really crazy day today.
These things happen. It's fine.
Yeah. So you're having surgery with Dr. Leslie, is that correct?
I believe so, yeah.
And your knee is the right knee?
My right knee.
Perfect. An arthroscopy. Right. And
Okay.
it looks here that you're pretty healthy.
Yep, I hope so.
No medical
Other
problems.
than the knee.
Other than the knee. All right. Well, we'll get that taken care of pretty quickly here.
Great.
So I'm just looking through this. Healthy, no medical problems except for the knee.
Right?
Allergy, it says, to penicillin. What happened with that?
It happened when I was a kid. I got these huge welts, these hives. I don't know. It's pretty bad from what my mom tells me. Hopefully it's not going to come up again, eh?
It shouldn't. It shouldn't
All
come
right.
up again. Sounds good. So hopefully we'll get going in about 15, 20 minutes from now. It won't be me being your anesthesiologist because
Oh.
we're sort of changing around.
Sure.
Dr. Shapiro will be your anesthesiologist. So
Okay.
she'll come over and introduce herself before she'll look through your chart. Okay?
Great.
Sounds very good. I need you to sign a consent form. A young, healthy guy like yourself, what I usually just tell people is nausea is the highest risk. Otherwise, it should be a routine fly ball.
Sure.
Okay?
Okay.
Have you sign this consent form, please?
Sounds good to me, doctor.
All right. Sounds good. Questions?
All right.
All right. Sorry
No,
that we're so
nothing for
late,
you.
and
Don't
it's
worry
just
about
a
it.
long
No,
day
no.
for everyone. Okay.
Maybe with the other
See you
doctor.
later.
That's fine.
Okay.
Yeah.
Good luck.
Thank you.
Okay, hi.
Hi.
Mr. Jinks?
Yes.
I'm just getting all cleaned up here.
That's fine.
Okay, there we go. Hi.
Hi.
I'm Dr. Joe Shapiro.
Okay.
I'm gonna be giving you your anesthesia.
All right.
I know you talked to my colleague.
Yes.
So he's
covered most of the bases then,
You
so
did.
we should be good to go.
Good, and I don't need to make you answer every question for
All
the
right.
20th time.
Perfect.
So we're just gonna keep moving. So first thing I'm gonna do is I'm gonna give you some, hang up some medications.
Okie doke.
And then we'll get you in there as soon as we can. I'm so sorry there was a
No,
delay.
don't
I know
worry
you've been
about it.
waiting all day.
I understand. That's
Where'd you
how it
come
goes.
in from?
Actually, not too far, so
Oh, good.
I could have come later, but here we are now. So.
Okay, no, that's a nice attitude. I like that. Okay, so we'll get that running.
Sure.
And then, for the most popular part of our armamentarium, I'm gonna give you some medication that is
Yes.
like giving you 3 cocktails.
Hi.
Hi, I'm Ann.
Hey, Ann.
I'm going to be your nurse today.
Great.
Alrighty. I'm just gonna be putting this in you. It is
Yeah,
really,
sure.
listen, let me tell you something about it. It can make you feel really strange. It
Good
will.
thing my wife
Okay.
is in here, right?
Yeah, absolutely. And we won't give you any math
Sure.
quizzes to
Please.
do. It's very,
fine.
very
Um,
powerful.
It's just going to work, right? It's.
Yeah, no,
doing
it
its-
should be coming in
How
right
does
about
it?
now.
Anything in the chest? I'm feeling a little
No,
tight.
it can make you
maybe?
feel just sort of strange, and that's very,
Sure,
very common
okay,
to feel strange.
a little.
A little out of it.
Breathing.
It shouldn't affect
It's
your
affecting. Yeah, no, it's affecting it. It,
Oh,
it
well,
is.
that's
It's what
not
it's
good.
doing. It's right
No, that's
in
not.
the
Oh, you
in
know
the.
what I'm seeing? I think
What?
he's got.
Oh my goodness, I didn't have that.
What's
Yeah.
happening?
Yeah. So
What's
it looks
happening?
like we think it's okay. Don't worry.
What's going on?
We think you're having an allergic reaction.
To what? What's going on?
You know what? We're just gonna take
No,
care of
you
that.
need help.
Yeah. Let's do this. Let's shut off the antibiotics, and then let me do this. Give me some epi, and also let's get him some O2. Okay. Let's do that before I get ready. All right. You know what, Steve? Here's what we're gonna do. We're gonna give you some oxygen. Just try to keep as calm as you can. We're gonna just give you some nice fresh air,
I'll
and
go
that
get
should
the epi
help.
for you.
Good. And then we're gonna give you a medication that should actually make this feel better. So hold tight, hang in there, and I'm gonna move up here.
And here's your epi.
Oh, great. Oh, let's do that first. Okay. Yeah. If you hold the
And I know
he's
you gotta
just
keep
yeah.
that mask on, Steve.
Just try to stay calm. We're gonna give you some medicine that should just about reverse all this. So hold on there for me, okay? Good. That epi's in. Okay, thank you. And then let's do this. I think he's gonna need an ambu bag. Okay? And then also, you know what? You can call for some help, whoever's available. That would be great. And let's put the head of the bed down too. Alrighty, good. Good. Okay, Steve, we're going to get some other oxygen. Just hang in there. I know. I'm sorry.
I'll go call the second
Good.
anesthesiologist.
Let's get that right on you, okay? And, yeah, let's get that moving. Good, okay, Steve. We're just gonna get you some, okay.
Well, the second anesthesiologist is on the
Okay.
way. What else can I do for you?
And I'm gonna need, I'm not moving any air. Give me the intubation set kit stat. Good, okay, good, all right. Yeah, no, he's not moving any air at all. Okay. Steve, I'm just gonna work on getting some air to you, alrighty, and then let's get this ready. You know what, Ann, why don't you, hold on to this?
Okay.
Okay, and then I'll get some gloves on and, here, just hold it. Yep, and then you know what, forget the gloves for right now. Let me just get this, see what he looks like.
I don't feel like I'm moving any
Yeah,
air at
there's
all.
really not much happening. Okay, all right, I'm just gonna open this now, okay. And that is not happening. His larynx is totally edematous. He's swollen shut. Okay, put that back on him, would you? I'll get some gloves on. Oh, thank you. And then I need 2 things. Cricothyroidotomy tray and also some colleagues out
Okay,
here. That
I'll
would be
see what I
really
can do.
nice too. And because we're really not moving air. Let's get on that. Okay. Steve, we're gonna get this set for you. Good. Let's get that right this minute. Excellent. Okay. Alrighty. Anybody everybody available to assist?
I know that the second anesthesiologist is on the way.
There you go.
Hey, Mark, thanks
What's
for
going on?
coming in. So he's got anaphylaxis and his larynx is just edematous. He has no airway.
What's the anaphylaxis to?
I'm not sure at this point, but I just needed to
We
get
stopped
his
the
airway.
You stopped the antibiotic
Yeah,
already?
we
Okay.
did. We're just assuming it could be,
Okay.
but let's just do
Are you
this.
getting anything in at all?
Not a thing, absolutely nothing, not a thing, so let's do that.
Oh.
All right,
I'll let you open that.
Yep, okey-dokey, and then.
Why don't you prep his neck and I'll just sort of get this ready
Okay,
for you,
perfect,
okay?
yeah,
You can
alright.
look, see
All right,
if
you know what, let's forget the prep, we don't, it's just.
Okay,
you
how
know
about
what,
extend
yeah.
his neck in if you can,
Let's
please?
do that, and I'm gonna get the landmarks, okay, and then I'll get that in.
I'm not moving any air at all.
Yeah, and his sats are how?
They look about 65, Joe.
That's not good.
That's not
Very
good.
Let's get the, wire. Good.
job.
Okay, good. All right, perfect, and then you take that needle for me if you don't mind, and
I
let's
have
get
it.
that knife, make a little nick there. What we have for that?
I'm not
Good.
moving any air.
All right,
There you go.
thanks, yeah, okay.
Sats are about 52 at this
Not good.
point.
All right, we're just gonna thread that.
I'll put this on if I can.
Good, okay, we're just gonna thread that over, and then next step.
Okay, Joe, you have that. I'm gonna let go.
Okay, excellent, got it. Okay, and then.
Nice
slide
job.
that
I'll slide
over.
the dilator
Good,
out
you did
and the
that.
wire.
Okay, perfect, and then what's sitting right up there, Ann? Thank you. Okay, and then let me just see how that feels. Oh, yeah, that should be in. That should be in, that feels like moving just great. What
I
is
see the
sats
chest
like?
rise.
Sats are about back up to about 75 and climbing.
Okay, good, that's good.
Good chest rise on both sides.
Good, ooh,
Okay.
that's tough. That's tough,
All right.
oh, okay.
Looks
Thank
like
you
you've moved a
so
little
much for
bit.
coming in.
Nice job,
Thank
Joe.
you.
And good job.
Thanks for helping out, that was key.
All right. Sounds good.
All right, thanks.
All right. See you later. I'll call the ICU.
Yeah, please,
All right.
absolutely.
Sounds good.
Okay, so let's just get this secured. Yep. Okay, good.
Oh, hi, Steve. Hi, good to see you. Hi.
Doctor.
Oh, I haven't met are you?
Yeah, I'm Kara.
Hi, Kara. So nice to meet you. How you doing?
I guess I'm better. I think that I've recovered. I think so. You tell me.
Sure. First of all, I just wanted to know, has anyone talked to you about what happened Has anyone talked to you about what happened yesterday?
No, I guess I woke up just about an hour ago. So I'm just learning what's going on.
Okay, alrighty. Well, this is why I wanted to meet with you. I wanted to tell you what happened yesterday and
Okay.
make sure that I answer any of your questions that I'm able to.
Sure.
So, as you know, we were getting you ready for your operation,
Yeah.
and in doing so, one of the things that we give are antibiotics.
Okay.
And we believe that you had a reaction to one of the antibiotics, which is called Keflex. And the reaction was very severe. As you know, you had the hives, but what really was severe was that your throat swelled inside, and so that you couldn't breathe, and we had to give you that airway that is now gone, but it was where we had to put the needle in the tube inside your neck to bypass that area that was swollen. And
Okay.
yeah, so that's what happened. And it was, go ahead.
Well, what it's called Keflex? What?
Keflex.
Keflex. What is it?
So,
I only have an allergy to penicillin that I know of.
I know. And essentially what we gave you was a relative or a cousin of penicillin, and really in retrospect,
Didn't someone take down this documentation? Shouldn't someone have known this beforehand?
yes, and that was our mistake. In retrospect, looking through all of the materials, Steve was very clear about having had an allergy that when he was a child. I don't think he was certain exactly what happened, but it would have been enough to signal that we shouldn't have given anything that was even related to penicillin, which Keflex is. It's not exactly penicillin, but it was a mistake. He shouldn't have gotten that.
But how did this doctor casually just ask him and then hang something up that?
I'm okay now.
But you could have not been okay.
But they did.
Yeah.
She did a great job. Look at me now, right?
Yeah, you've got a really cute thing.
I'm sorry. It was a mistake, and what we do when this happens, first of all, is to tell you what happened and apologize, because really it shouldn't have happened. There's no question about that.
I agree.
Yeah. In terms of figuring out, I think the first thing is to let you know that as awful as it was, and I can't even minimize that, I can't imagine what it would have been like to go through that, this shouldn't have any long-term consequences for you.
Yeah.
For us, we really need to look at why this happened. Because whenever something goes wrong, whenever there's a mistake, it usually follows a complicated series of answers to the question that you raise, which is, why, how could this happen in this hospital? How could it happen anywhere? It's a very good question. And it's our obligation to really look into this and to pick apart all of the things that could have led up to this happening. I do accept responsibility for actually putting the medication in. And then I think I'm going to be working with my colleagues to figure out how I could have made that error. It may not be any comfort, because it wouldn't, we can't go back and undo it, which I wish we could. But
So, where do we go from here? I mean, I assume I didn't have my surgery. We have to go back into the surgery room?
Yes, I think obviously we want you to recover. And again, as awful as this was, it shouldn't have any long-term impact on anything. It has nothing to do with anything that would cause you harm or difficulty in another operation.
Okay.
You seem understandably upset.
Well, at least I'm here now.
Yeah. Are there questions that I could answer that might be helpful to you?
No.
I mean, other than, I think we're all looking for the same answer of how this happened, and I guess we don't know yet. Is that right? We don't know.
Well, we really don't know for us, like I said, and to prevent this from ever happening to anybody again, which I know is not going to affect you, it's our commitment to really look at how I could have hung the wrong medication. And as a hospital, we're always trying to improve, and we feel that we have to be able to make it safer for patients. And one of the ways to do that is to look at when things go wrong, look very carefully at it, have a team of people look at it, and see what are the steps that led up to my making that mistake. I'm really sorry.
Well, thank you for apologizing. That helps. That helps with me, my I don't know, dealing with all of this, and definitely people recover from this. The hole in the throat, the tube, and everything.
Yes, it really should leave.
Okay.
What we will do is we're going to have an otolaryngologist, ear, nose, and throat physician just check everything, make sure things look fine before you go. As I said, though, I spoke to one of them, and he doesn't anticipate there should be any problems. But of course, we'll have you checked out for sure.
Okay.
And the other, yeah.
Yeah, I'm fine.
Well, you seem upset.
Yes, but you're okay.
It is upsetting.
Thank you. I guess thanks for doing this. This is it answers some of the questions, but let me know when you figure these out.
Yes,
what happened,
please.
please.
We will, and I'll make sure that I or somebody from our team gets in touch with you when you're home at some point when we have some more answers that might be helpful for you to frame this a bit. Okay.
Okay.
Alrighty. Take care.
Thank you.
Steve, how does that feel?
I mean, it's helpful. Thank you. It's definitely helpful, but it's with only the 24 hours since the mishap, without there being any answers. It's sort of you're left wanting more, kind of, But getting into the loop in terms of solving this, what happened, that's helpful, and the admission of fault, I don't know. It does help with, this and everything. But.
Yeah, that seems sort of, I think it was the not having the answer of what happened. So it's good to have, but it felt like, okay, well, if he explicitly told someone, it wasn't as if it was unknown or if it was a complication. So I think it was the not having the answers of, okay, how did this mix-up happen? I think that was the
tough part.
Yeah.
And what do you think what she should have said to try to clarify that for you?
That's the tough part, because I don't know if there is any. I don't know if there is anything you can say when there's, when it's an unknown, right? But knowing that it was a cousin drug of penicillin, that it was clear on the forms, so it feels like the solution is, or the answer at least, is coming. That was helpful, and then also the clarification that there should be no side effects from the
Whatever.
The hole in your neck.
Yeah, the hole in my neck. You guys are talking
It's fortunate that your anesthesiologist was also on ear, nose, and throat.
Yeah, I thought I put a plug in for.
Yeah.
That's what we need. So, yeah, I mean, it's obviously we're dealing with like a best of the worst scenario, making the best of the worst situation. And so, I think Joe really covered what there was to cover at the time.
Can I ask Joe a question then? So Joe, what I'm hearing Brady say is they sort of wanted more of what actually happened.
Yeah.
How do you feel about that?
Well, I think you both, by the way, did an amazing job. So thank you. Well, some hands for the. And it is amazing how real it feels. It really does to me. So I think it's where only my training in disclosure helped me from speculating. What I wanted to say was, well, if my associate had signed this out to me, I wouldn't have hung the capsule. But, this idea of, we know what happened, so I wanted to be clear, this is what happened. As in terms of, I was trying to say that, which is true, that anytime something goes wrong, there's the sharp end of the error, which I was at, but there's going to be multiple steps that, as an institution, we have to look at. And I was tempted to speculate because I knew that you'd feel better if I gave you more information. But that's where, as Les was saying, that gets us into trouble, and it's not fair to anybody for me to speculate as to why I did that. It just isn't fair, even though in the moment I'm dying to do anything to get your emotional negativity down. So it was kind of tempting, but I just said, I just can't do it. I mean, to myself, I just have to tell the truth, which is, this is what I know now.
Yeah.
But it's hard.
Right. It's understandable.
But I'm feeling that's not 100% transparent because you knew that the previous anesthesiologist didn't pass this along, and you knew that you didn't look at the chart to look for it. So,
well,
but I know you're trying not to speculate.
Well, what's speculative is, really, how do we have a system where that would be allowed to happen, if you will? Not to take the onus off of either of us, but I think I was clear what happened. I think that was the most important, and that's when we teach disclosure. We try to say, if we tell everything you do know for sure. And sorry, the other thing I wanted to say was, and you commented on this in the debrief, was I wanted to make sure that I was clear that it wasn't your fault, that you were clear that you had a reaction. Because what I think sometimes happens is we're kind of hoping this is completely unconscious, that in some way it won't look like our fault, and somehow, you know, it will be, well, maybe he didn't really say what, you know, what happened, his previous reaction or what have you. And what happens is patients, if you're not explicit about saying, no, you were clear, they will take blame upon themselves. It's a very natural thing to do. And, you know, it feels good for us because it's like, yeah, not my fault. But it's just the wrong thing to do. And so I wanted to be clear that I knew that he had, you know, we looked through the chart and I knew that you had said to my associate what happened. Then what happened? Why was it that did I not look at the chart? Was the sign out not quite right? Maybe we don't know. I mean, I'm assuming we don't really understand exactly why I did that. That makes sense? Yeah. And that's kind of, you know, when you look at root cause analysis, if you start saying the word root cause analysis and systems and Swiss cheese and all that to a patient, it's like, they don't know what you're talking about. And so I just wanted to say this is what we know, and we're going to look into sort of more of the why. We know what, look at more of the why, and we'll get back to you. Okay, so first of all, thank you for having me, and it's wonderful to be here. I know so many of you, and I think this is an amazing institution. I'll get back to the beginning of my slides, but what I thought I would do is just dive in for a second and ask you to think for a minute of a time when you made some kind of medical error or mistake that caused some degree of harm to somebody. Just think about that. So I never leave a long time for that exercise because every clinician I know, we carry our errors right there. I mean, never mind the 10,000 things we've done well, but almost every one of us has one or two things that went wrong that we will never forget and that come up really quickly. So now what I'd like to invite, and this is not a requirement, and I don't want to hear necessarily the specifics, but can you remember what emotions you might have felt? Name an emotion that you felt when something went wrong. What did you feel in the moment? Somebody say panic? Yeah, panic. It's scary. What else? Embarrassment, yeah. I mean, there's a sense of shame. You know, you're no problem. We're clinicians. We went in this to make people better, and now we've made somebody worse, and that's pretty horrible. Let me just see. Is there a remote mouse by chance?
No.
Okay, I'll need to. Could you? Thank you. Sorry. Yeah. Can you?
We have to get the slide projector on too, please.
Oh, okay. All right. So there's a gentleman named Helmreich who looked at the similarity between the enculturation and professionalization of physicians and that in aviation, and he found that both stress the need for perfection and a sense of personal invulnerability. And I can tell you, you know, when I did my surgical training, now this sounds completely delusional, but I actually thought complications and errors were things that were going to happen to other people's patients. Even through all the consents I had patients sign, I never actually believed in my heart that any of those things would happen, because we were taught if you show up and you are that educated and committed and diligent, that things won't go wrong. And of course, we know that's a complete fallacy. And we need now to switch how we train, and we need to train in anticipating errors, because what I've learned around studying the people who've studied human factors is that we're error-making machines. I mean, think about the last week. Not that you've harmed a patient in the last week, but think of the things you forgot, your keys, an appointment. We forget, we slip up, errors of omission and commission regularly. And so what we need to do is the system is, first of all, individually, we need to be as ready and as educated and skilled as we can be in every moment. And we need a system that will anticipate that even with that, because we're human, we will slip up. So we need to set the system up to anticipate errors. And I don't know about you, but I was not trained for that. I didn't really get that. I don't think we understood that. And we're switching over to that now, but we've got a long way to go. So I want to just go back and say, oh, I have to say this. Okay, enough about my husband. I just wanted to thank all of you here, but particularly Mark and his team for doing this. It's wonderful. You have a great crew. These are just some of the people who have been involved in helping us move this forward at the Brigham and some of the other hospitals. So there's tons of people here. But so in the Center for Professionals and Peer Support, we do lots of things, but one of them is in disclosure coaching and peer support, and that's what I want to talk about briefly today. Okay. Thanks, Mark. So we did that. We did that. Okay, so I'm just going to say that we know that the most important people impacted would be the patient and family, but so is the physician, and so is the rest, can be the rest of the team. I mean, it's really not just one person or two, and sometimes the entire institution is in some way traumatized. Okay. So there's sadness. I mean, we feel sad. We know somebody's suffering. We don't like suffering, and it makes us feel sad. And I felt sad with Steve there. It's sad to see somebody hurt in some way. And then following close on those heels, that's a sense of shame and embarrassment. We've let ourselves down, our patient and family down, and we've let our colleagues down in some way. And I think after we talked about the shame, I think the other thing that creeps in is a bit of fear. And what might we be afraid of in the moment?
Litigation, our job.
Yeah, we're afraid our reputation, our job may be in jeopardy in some way. Will we get sued? I mean, that's scary stuff, and that all floods in. It just, all of these things I think flood in. Now, what I wanted to say is that it's not like I've experienced these so many times because I've made so many errors, and that's why I'm an expert in this. I have made my share, that's for sure. But what I'm presenting here comes from both experience and speaking to colleagues, doing some research, and also reading the literature. And it's just my way of conceptualizing this kind of impact. So the other thing I wanted to ask you is, did you guys get the memo, by the way, a couple of years ago, I think it was, or maybe like even a decade ago, that we don't do shame and blame anymore? Did you? No? Yeah, I didn't either. Okay, so we know we're not supposed to do shame and blame, but what is the first thing in medicine and also in society at large when something goes wrong? Whose fault is it? We all think that. I think it too. And I've had this terrible reaction sometimes of when my colleague or somebody I know does something wrong, is this split-second thing without thinking going, I wouldn't have done that, right? You know, it's just automatic. It's human. It's okay. It's okay to feel these things, but we have to manage these feelings, is what I would say. And the other thing I want to say is that nobody feels, there's no process. There's no Kubler-Ross thing, which has been debunked as far as there being an order to grieving and what have you when someone dies. There's no, this is what you go through the stages after something. So these are just a mix of emotions that people feel to a greater or lesser degree after errors. And so, now let's just say, you know, when I first did this, people would say, why are you doing this disclosure? Why are you, this was like when we started this, I don't know, more than 8 years ago, because the malpractice system is all shame and blame. Even if we had our act together in the hospitals and we didn't do shame and blame with ourselves and colleagues, obviously the tort system is shame and blame. It's your fault. It's her fault. And so why are you doing this? And my answer was, because we have to do this. We have to disclose transparently and compassionately. We all agree, everybody agrees, because it's the right thing for the patient and family, even if it puts us at risk. So even though we now know, as Les showed us, that if you do this well, it's actually going to have less chance of getting you sued, that's not the reason to do it. We have to do this because it's the right thing. But what struck me was when people were going around the country saying, you have to be transparent and compassionate, and it was like, and why are we and we know we do this badly, by the way. We have great literature for that. Tom Gallagher showed this without beyond the shadow of a doubt. We're not good at this, okay? The problem is that we're asking people to do something at a point when they're emotionally vulnerable. So instead of just shaking our finger at each other, let's identify the barriers to doing this well and help us overcome them. So I think we have this sense of fear we talked about, and then there's some anger like, wait, I thought this was no shame and blame, and there's a gap between what we know should be the way the system is and the way it really is. And the other thing is, I think we have this fantasy. Mark, do you mind just advancing? I'm not hiring you again for my... So we talked about that quote. Yeah, go ahead. Okay, go ahead. Yeah, that's what we hope happens. Right? Now, Steve was trying to say that, but his wife was like, I don't think so. No. And this is a really, I think, important point, and that is, I don't believe that it is our job to get forgiveness from the family. I mean, I wanted it from them so much. I wanted to give them you tell me what you want, I will give it to you right now so you're not mad at me, was kind of how I was feeling. But that's not the family's job. If they do this and they give this is a gift, take it, it's wonderful. And many patients will do this. But it's not their responsibility. It's our responsibility as a community to help us forgive ourselves and to forgive each other. And that's where we're going with this. How do we do that? Okay, so next, yeah. So this can be the reality. And one of the things that I find very frustrating, especially as a surgeon, is I really do like to control things. That's why I went into surgery. And once something has gone wrong, you don't have any control. I didn't script with either of them beforehand. I said, you can say anything you want. Just try to imagine how you'd feel in this circumstance. I didn't tell, I said, other than throwing something at me, you do whatever you want. And I said, probably be better if you didn't just say, that's okay, doc, I know you're trying to help me. You know, other than those two extremes, do what you want. But knowing that I was going to have to do what we would have to do in the real world, which is listen for their reactions. Don't try to control them. Don't try to manipulate them, even though I'm dying to. Don't let them be whatever they are. And that is hard, because you really don't want to hear the anger and hurt. You know, if somebody cries or they've lost trust in you or whatever, that's hard. But that's their right. They're allowed to feel what they feel. Okay. And I think all of this leads to a sense that we're alone, because what's the first thing back in the day that risk management or your department chief would tell you when you report something went wrong? What was the first thing that you were told?
Don't tell anybody.
Don't talk to anybody. Now, I want to say that hasn't gone away, because there is a reason to not go just talking about this, you know, down the hall or wherever. It's because whatever conversation could be held against you if this does become a lawsuit. So there's a reason to say that. But we've made a system to work a little bit around that, because we understand that being left alone and isolated after this is a crime. It's just not conscionable for us to do this for each other. So how can we not leave people alone but still protect them in this environment? Okay. Again, I never tell somebody what to feel or what not to feel, but did anyone here read The House of God? Love that. Do you remember, what does he say? You're racing to go to a code. Before you go in the room, what are you supposed to do?
Make your own call.
Exactly. So my analogy is take your own emotional pulse before you make the disclosure, you walk into that room. Now, it's not to say you shouldn't feel guilty, you shouldn't feel ashamed. You're going to feel what you're going to feel. Same way they're going to feel what they're going to feel. But if you walk in with those emotions, they will lead to some of the following things that are bad. And this is what led us to understand that we don't do this well. And I'll show you what those are. Okay. So this is Tom's research, if you want to look it up. He's really smart. I really love working with him. And there's a big gap, trust me. Okay. So I'm making the case that we're doing the right thing. We have to do this morally, right? Compassionate, transparent. It's the hardest task at the time of maximum clinician and patient vulnerability. There's a gap between what clinicians feel able to do and what patients experience when we do this. And it requires skill and sometimes advice, and support is crucial. Okay. So here are some of the things that go wrong. People walk in and I could have said, hi, Steve, I just want to, and he wouldn't tell you what happened. No, well, what happened was there was some, you had some kind of reaction to something, and you had trouble breathing, and we had but thank goodness we put an emergency tube in your throat, and whatever reaction that was, it's all gone now, and it's just not likely to come back again. Or even more than that, I could have gone in and said you had an anaphylactic reaction to an antibiotic, which was a blah blah blah, and I did an emergency cricothyroidotomy, and that did, and he. Now I'm telling you, I could tell him exactly what happened in medical terms, and he wouldn't know. And we do this all the time because we're scared, because of all those human emotions, and so we tend to obfuscate. And patients come out thinking there's something. She said something. I don't think things were right, but I don't know what. I think she's hiding. And you've heard this, and I know it's true because there's some documentation of this. Many patients, when they sue for information. There's no question about it. Even if we think we've told them, we've not told them in a way that they could understand. And then sometimes there's this defensiveness, frustration. It was hard to sit with, Kara getting angry, right? It's hard to sit there and then to be quiet and listen, to give her enough space to talk and emote. Sometimes people walk in and they go, oh my God, Steve, I can't believe I let this happen. This is my fault. I've never done anything like this. Is the worst thing I have ever done in my entire career. I'm devastated. I can hardly sleep. I am so sorry. Now, why do you think people do that? It's cathartic, and we want to be forgiven. We want Steve to feel so bad for us. He's like, it's okay, you're good, don't worry about it. Get out of my room. It's natural to do, and I'm exaggerating, but people do, they overblame themselves. Or what I said that I wanted to say about Mark, people do this all the time. They do. And the other thing that happens, and this is more complicated, is when they're cover up for someone else. Okay, they don't want to throw someone under the bus, so they kind of don't really say what happened. There's lots of things we do wrong, but we can help with this. That's why we do disclosure coaching. We try to help anticipate some of the pitfalls. Okay, so basically the principles are.
I'm working with you, Brian.
You need remediation. Okay. Okay. So disclosure should be. I was really glad though to have Mark walk back in the room when I was doing the. I can't tell, doing the simulations, Jeff has taught us, but you really feel caught up in it. I mean, I did not feel like I was in a simulation. I was like, oh my God, this guy's losing his airway. Mark, where are you? Okay, so I think disclosure should be an opt-out process. There's a lot of rationalization. I don't think they need to know, and there are ways that patients could easily not know about something if we didn't tell them, not in this situation, obviously, but they could not know there was an error. Well, it's just going to upset them. They're fine anyway. It's going to have no long-term impact. My view is if you're going to make a decision not to disclose, you need a second opinion because you have a conflict of interest. Part of you does not want the patient to know whether they should or not. So it just should be a conversation with somebody who knows how to do this, and usually that's risk management and any disclosure coaches. If you decide not to disclose, we talk, okay, blah, blah, yeah. Alrighty, so it should be as close and proximal to the event, but my saying it to, telling Steve as he's being wheeled to the ICU is not the time. It just isn't, but pretty as close, as proximal as possible. Okay. We agree completely with your policy. It should be the attending. If there's a resident involved and the resident, you've had a discussion beforehand what's going to be said, and the resident, we like the resident to come with us because they should see what this is like to do for that rare moment, and it's going to be rare. That's why none of us is an expert in this unless we do this for a living, if you will. That resident will have a little bit of a sense of how to do this. But I don't think the resident should be disclosing the error, even if the resident made the error. I really believe that. That's not fair. It's too hard. Okay, yeah. And then, except for, remember I said, leave your emotions at the door? Well, Meg Gaines is a patient advocate. She's wonderful. She works at University of Wisconsin. She and I worked on some of this together, and she goes, don't tell them to leave all their emotions at the door. There's that empathy that everybody feels as a clinician if something goes wrong. That's what the emotion you want to lead with. You just have to name your emotions to yourself. I don't mean out loud, but that will let you not act on them. And my sister and brother-in-law are practicing clinical psychologists, so they've taught me a ton. We have a Friday night dinner every night, so I get a lot of therapy, whether I want it or not. But this idea of just acknowledging what you're feeling is obviously very helpful in not acting on it or not being controlled by it, if you will. I think one of the things that I've noticed when we do disclosure coaching or when we do training is people will go right to the root cause analysis. And it turns out, now they were interested in that, right? But a lot of people, they don't care. They want to know what's going to happen to me. And we had that in the training session was, you know, with the person doing the disclosure go, well, we're going to have a team and we're going to look at this. And they're like, what about, am I going to need, and you know, we had a different scenario. So the first thing is to talk about their immediate medical and social needs. I mean, what you think are their needs, and then make sure that those questions are answered. And then we talked about how hard it is to do this. Now, why is this so hard to do? Why do docs so often speculate? And because I kept seeing this happen when we would do disclosure training, and then we do a role play, and we go, don't speculate, and the person, and then the family would go, well, but why did this happen? Well, we think it was this, but it could have been that. And I realize it's because we're always speculating as physicians. It's a differential diagnosis. I think you have this for these reasons, but you know, it could be B, C, or D, and if that, and so you have to go against your training and just not speculate, even though it feels good to try. And then, but don't hide what you know to be true. So if they'd asked me a question directly that I hadn't already disclosed that I knew, of course I would tell them. I wasn't purposely hiding anything. Okay. Here's the thing. So there are times, and I would say, I'm going to almost say most times, where you're going to use the word sorry, and it's in the context of an empathic statement, not an apology. And that's okay. Don't worry about the word sorry. So this is my analogy is, you know, if I'm running down the hall, like looking at my BlackBerry, and I slam into Mark, and I go, I'm sorry, I'm saying I'm sorry apologetically, like I'm accepting blame that I did this and I apologize. But if we're walking down the hall and I go, hey, Mark, how you doing? And he says, oh, you know, my great-grandfather died. And I say, oh, I'm sorry. I'm not worried he's going to think I killed his great-grandfather. Right? It's contextual. The word sorry is totally contextual. Now, is it possible the patient would misinterpret? Just use the word for empathy that is natural to you. To me, I can't find a better one than sorry. I'm so sorry this happened. You didn't get me, I did an apologetic sorry. Okay, I accept, you know, that I did it in that context. But if we weren't sure there was an error, or who made it, or what have you, that there was an actual mistake, then it's better to say, I'm so sorry this happened, it's not what we anticipated, you know, and then we're going to, well, was there a mistake? You know what, we're going to look into this, and we will get back to you. And then if we find, yes, it was an error, then we go in and we say, we're sorry. So I'll give you an example of where people apologize, and once you've apologized, as Les was explaining, even protection under the law does not work. If you apologize for something and it turns out that's not what happened, you can't go back and unapologize for that. So we had a patient who was, this was several years ago, many years ago, was in the IC, he was on the medicine service. He had DTs, and he also had some epistaxis that was reasonably controlled with a pack. He had a little bit of oozing occasionally, and he coded. And as he was being wheeled out of the room, the medical resident apparently said to the family, he's choked on his blood, and that's from his nosebleed, and you know, now he had a cardiac arrest, and now he's going to the unit. Well, that was throwing our service under the bus. Actually, that was wrong. That is not why he coded, but it was very difficult to explain to the family without sounding different. That's not actually what happened. So it's very important not to say, I'm sorry we did this to you, or I'm sorry we made this mistake, unless you're sure it was, and I was in this situation. That's really important. Other than that, empathy, it's always good to say, I'm so sorry this happened. I hope this is hard. By the way, none of you is going to be an expert, and that's not the goal of this. It's to sensitize you that this is harder than we think because of all the human emotions, and it's complex, and you have wonderful support to walk you through this before you go in the room. And if you have to do it in the moment, you do the best you can in the moment, and then you can go back and have more of a conversation. Okay, so feel free to say we don't know yet, which is what I was saying a lot of. Explain the process, what's going to happen, and I talked about this, and then I hope I did it. I mean, it's hard to know in the moment, but just say, did I answer your questions? You know, did I Basically, is there anything else I could answer for you that would be helpful? Or I might have said, and I don't think I said this, but it might have been nice to say, is there anything else we can do for you at this time, or I can help you with now? Just to make sure. And then we do have resources to support patients, it's social service, it may be financial support that we can bring to bear, but I don't have to take care of it all now. I just need to ask about it. How are you doing, or do you have any other questions? Okay. So I do really believe that even though we're talking about, in some ways, a massive culture change here in supporting each other in ways that we hadn't before, even though we're talking about being transparent in patient situations where we haven't been in the past, I do really believe that the culture change is very much in our hands, because there's no culture manual. Right? It's what we do every day. It's your choice to have a combined grand rounds that addresses something that isn't scientific, if you will, although there's science behind it. That's a cultural statement that your leaders have said this matters and have shown up here. You know, that your educators and your experts are putting this into, this is why we're going to change it. So I feel very confident that we've already, and I know you all, I know because I've worked with a lot of you, are already much better at this than many people in the country, and certainly we're all better at this than we were years ago. So I think we're going in the right direction. So thank you for engaging. I hope that was helpful, and happy to take any questions. Thank you.